Good morning, everyone. Today we were going over modifiers. We'll be going over several different types of modifiers. For anyone watching this on the replay, my name is Kristen Robinson. I have the Coding Corner. I'm the founder and educator for the Coding Corner. I have a group on Facebook if you'd like to look that up and get more information, or you can reach out to me directly. I have my CPC, CPMA, CCC, and CRC. Today's agenda is going to cover the definition of a modifier, the modifier categories, the modifier list of a more complete look of modifiers, global modifiers, modifier FT and surgical modifiers, and then just a few other modifiers that don't fall into specific categories. So let's start off with what is a modifier. So a modifier, quote unquote, modifies a procedure or an item, and it adds additional information or changes the description based on the documentation provided by the physician. So CPT modifiers are added to either CPT or HCPCS codes, and this just provides additional information on the claim for the insurance to understand the situation and clarify what happened during the procedure or the evaluation and management service. So CPT modifiers have two numeric digits, and they are copyrighted by the American Medical Association and are updated annually. Okay, so the American Medical Association, if you're not familiar, is who creates our all the material for our CPT books. So this is super important to know if you're just starting your journey, if you've been in your journey with coding for years. It's very important to stay on top of modifiers because sometimes they add new modifiers, they will update the definition of them. So it's very important to understand not only what they do, but how to appropriately append them on your claims. So let's talk about our CPT modifier categories. So modifiers are divided into three main categories, and the categories modifier range from 22 to 99 is called provider services and ambulatory service center modifiers. Your second category, also known as performance measure modifiers or category 2 modifiers. These are used to indicate that a procedure was considered but not performed due to medical reasons, patient reasons, system reasons, or system circumstances. And then you have the third category of CPT modifiers that are used to describe anesthesia services, known as anesthesia physical status modifiers. So I know this is probably hard to see. It is a very large, all-encompassing list of the modifiers that are out there. Now, in today's presentation, we will not be covering every single section of modifiers. This is a high-level coverage of what I consider to be the most used, the most needed modifiers that we see on a day-to-day basis. Now, depending on the specialty you're in, there's going to be some of these modifiers you're going to see every day, or you may not see at all. If you're not coding, say, for instance, anesthesia, you're probably not going to use the anesthesia modifiers because not every specialty uses those. So, like I said, there are some modifiers that are across the board, pretty much every specialty uses. And then there are modifiers that are specific to a specialty in itself. So like I said, anesthesia, or if you're coding cardiology, vessel modifiers, those are typically only going to be used in the cardiology specialty, whereas say for instance, evaluation and management services are typically used across all specialties. So let's start off with global surgery modifiers. So these are going to encompass your 24, 25, 54, 55, 57, 58, 78, 79, and your FT modifier. So these are going to be your modifiers you're going to use either on an evaluation and management service, which applies to your 24, 25, or your say your follow-up, either all your surgical procedure information for 54 or your follow-up information. This also involves your staged modifier for 58. 78 is return to OR that's related to a surgery, and 79 unrelated to a surgery. So we'll be going through all of these in and of themselves throughout the presentation. So let's talk a little bit about the global surgery period and the definition for those and how they are used. So zero global period is usually going to be your endoscopies and minor procedures. These are going to be simple things that can be done in the office or considered very straightforward. Therefore, aren't it isn't necessary to have a global period. Your 10-day global period is going to be other minor procedures. These can also be done in the office. Some of these are also done in the hospital. It just depends on the type of procedure it is. And when you have a global period starting at your 10-day and your 90-day, basically what that means is if it's the day before surgery, the day of surgery, and the additional 10 days of surgery or 90 days post surgery, any services that are related to that procedure are included in the cost that your provider has already been paid to perform that procedure. So you're not going to be billing additional evaluation and management services that are directly related to the procedure that was performed, or if it's a follow-up procedure directly related to the procedure already performed that doesn't require a return to the OR. Those type of things are all encompassed in what they were already paid. Now, if your provider is doing something outside of the scope of the procedure or unrelated to the procedure, that's when you're going to use these modifiers to separate them from what was already performed. So with your 90-day global, this is really mostly going to be major surgery procedures. These are the ones that always occur in the OR. These have longer recovery times. These are more intricate procedures and things that are higher risk procedures than your minor procedures are. We also have three other categories: your triple X, your triple Y, and your triple Z. So your triple X is going to be that the global surgery concept just doesn't apply. So that's something you need to get familiar with when you're looking your codes up to ensure that you're billing it appropriately. Triple Y means that they are contractor priced, meaning the price may vary. Your triple Z are going to be your add-on codes, which means they require a primary procedure to be billed in order to bill that service. So let's get a little bit deeper into each modifier that we just discussed on the previous slide. So modifier 24, this is going to be an evaluation and management modifier that you're going to use to tell the insurance that this evaluation and management service is outside what the procedure was done for. So they're having a completely separate issue, an unrelated problem that is not directly tied to what the procedure was done for. So, by definition, as you can see on the slide, it's an unrelated evaluation and management service by the same physician or other qualified healthcare professional during a post-operative period. As we spoke about previously, that's going to be your 10-day or your 90-day global period. The physician may need to indicate that this service was performed during the postoperative period for a reason unrelated to the original procedure. So you need to make sure that your providers are documenting appropriately to be able to signify that this service is in fact not related. So now we have our modifier 25. So this modifier is also an evaluation and management service modifier, and this is going to be on the same day of a minor procedure. Okay, so this is when there isn't a global period involved. This is going to be typically your office procedures that are done on the same day as an E&M service. And what you're doing is you're appending this 25 modifier and you're telling the insurance company that your evaluation and management service can basically stand on its own, separate from the procedure. Okay, so some caveats to this that you really need to pay attention to when you're billing is a lot of times providers just always want you to put that modifier 25 on there so they can get paid separately for the E&M visit. But what you really need to take into account is what did they document? Does the documentation actually support that a significant separately identifiable E&M service that was this is key, was above and beyond the other service provided? So if you were to take away everything in that E&M service that directly related to the procedure performed, would you have enough information to separately bill that E&M service? That's what you need to ask yourself every time you are going to append this modifier, because I can tell you from personal experience that these insurance companies, that's exactly what they're doing. Okay, they are looking to see, is this actually separately identifiable from the procedure being billed? Okay, so now we're going to get into modifier 54. Now, modifier 54 and 55 may not be, I would say, as popular as, say, 24 and 25 are. Those are very, very common. But I did want to include modifier 54 and 55 because I feel like because it's not used as much, people don't understand the concept as much. So, modifier 54 is surgical care only. This means that your provider is essentially just providing the surgical service itself. Okay, services billed with the 54 modifier are reimbursed at the intraoperative allowance for the surgical procedure itself, meaning that they're getting paid basically for the procedure it alone. They're not getting paid for the additional post-operative care that is included in the remaining portion of the global procedure. Okay, so it allows them to be paid for the 1 day pre-op, the intraoperative service, as well as what is done in the hospital before they go home for the remaining portion of the global period. So then that comes in with your modifier 55. So this is your post-operative management only. What this is saying is that if your surgeon and the second physician has made a written agreement, and insurances like to see that letter of written agreement that provider A is performing the pre-op, intra-op, and the care during the hospital stay, and provider B is providing all the post-operative management past the hospital visit. So make sure that they're doing their appropriate documentation that is required to bill the 54 and the 55 appropriately. So let's talk about modifier 57. So modifier 57 is going to be your decision for surgery. So a couple very important key points for modifier 57 is that you're only going to append that to your E&M service if it is the day prior to surgery and they make the decision, or the day of surgery and they make the decision. If your doctor sees the patient in the office or whatever a month ahead of time, a week ahead of time, whatever, you cannot append a 57 modifier because it only applies to the day prior or the day of the surgery. So modifier 58 is a procedure modifier. This is something that you are going to append to the procedure, not the E&M service. So this is a staged or related procedure that is performed by the same physician or other qualified healthcare professional during the post-operative period. So typically the documentation that you want to see in order to appropriately bill a modifier 58 is in the original procedure note. They either couldn't perform the second service, or it's one of those procedures where it may require an additional debridement, or they did a PCI on one vessel and they're staging an additional PCI. So they're telling you in the note, I'm not performing this today. However, we're going to bring the patient back at whatever date, a month out or whatever. And they're telling you, I'm staging this procedure. I'm telling you that when this patient comes back for the second procedure, it is related to today's procedure. So just remember that a return to the operating room in which where they are not staging it, you're going to use your modifier 78, which we're going to talk about a little bit further. Basically meaning 58 means you're bringing them back. You've already decided that it needs to be a second time in the OR. 78 means it's related, but you didn't necessarily plan for it or anticipate the return to the OR. So a little bit deeper into the modifier 78. Like I said, this is a unplanned return to the operating room by the same physician or other qualified healthcare professional, but this is related to the procedure during the postoperative period. So the next modifier we'll be looking at is 79, which means it's an unplanned return, but it is unrelated to the previous procedure. So that's why really having knowledge of when it is appropriate to append these modifiers is so important, because if you're appending them inappropriately, you're actually billing it to the insurance and not giving the full story. So if your provider wants you to put a 58, or you're putting a 58 on it and the documentation does not substantiate that it was staged, the insurance is probably going to deny it because there's not um, documentation proving that it was in fact staged. Like in this case with the 78, you want to have the documentation that supports that it was unplanned and related to the previous procedure. On a little side note here, I did also add that if it's a repeat procedure on the same day, you can bill the 76 modifier for a repeat procedure, but that has a little bit different rules than the 78 modifier does. So our modifier 79, okay, we talked about it a minute ago. This is also an unrelated procedure by the same physician or other qualified healthcare professional during the postoperative period. But the main takeaway on this is that it is not necessarily part of what they believe the original procedure is due to. This is unrelated to the previous procedure. And again, I put the note on here that it has different rules than a repeat procedure on the same day where you would use the modifier 76. So now let's talk about modifier FT. So if you all have been in the coding world for a while, you know that this is a newer modifier. This is not something that's been around forever. But this is an unrelated E&M visit during the postoperative period or on the same day as a procedure or another E&M visit. So this is specific to critical care services, okay? Critical care visits that are unrelated to the surgical procedure but performed on the same day, or when critical care services are provided during a global surgical period and are unrelated to the surgical procedure. Okay, so remember, FT is an E&M modifier, not a procedure modifier, and it is specific to critical care services. Okay, so this is an overview of our surgical modifiers. Okay, so we're going to get into a little bit more detail on 22, 50, 51, 52, 53, and 62. These are appended to procedures, not evaluation and management services. I want to make that clear, just like I did with the other modifiers we covered, because you don't want to append them into the inappropriate service. Some of these are specific to procedures, and some of these are specific to E&Ms. With surgical modifiers, they are specific to procedures. So we're going to start off with modifier 22. Now, this is a very disputed modifier. A lot of providers want it because they feel like their documentation, their work was well above the average. You know, I had to change out, different wires. I had to change out, different catheters. I had to, go up on the French. I had to, all these different things. And they believe that it supports a modifier 22. Now, a modifier 22 is simply stating that the provider's work was over and beyond the reasonable amount of time or effort that is included in the procedure itself. But remember, it's not just about what they did. They also need to give you how much extra time did this take, because there are standards for procedures. So if on average, say for instance, a heart cath, if on average it takes a provider to 15-25 minutes to do a standard left heart cath, which is the most common billed cath out there. But your provider spends 35 minutes because he was having trouble with, getting through the vessel or whatever the case may be, moving across the aortic valve. Just simply because it took him a little bit more work doesn't necessarily mean it's going to constitute appending a 22 modifier. Okay, or there are other circumstances specific to cardiology, because that's my major specialty, where a provider may have some issues with a PCI and they want to bill a 22. The main takeaway here is it needs to be not only increased intensity, it needs to be additional time, technical difficulty, and even severity of the patient's condition. If the patient is severely dehydrated and they're having to put fluids in, or if the patient is under moderate anesthesia and they're not doing well, there are many reasons why the patient's condition could affect the amount of time or effort it takes for your provider to perform a service. But remember, the main takeaway with this modifier is they must document it. They need to tell you a full clinical picture of why it took them longer or what they had to do that was over and beyond the typical amount of time or the typical procedure itself. Modifier 50 is going to be your bilateral modifier. So there are some insurances out there that like to see two lines with a right, an RT modifier and a left an LT modifier. And then there are some insurances that want you to bill one line with a 50 modifier when you're billing a service that allows a 50 modifier. You really need to know your payer's information when it comes to that. But the main takeaways for the bilateral modifier is you need to remember that your procedure has to be an anatomical procedure. So you're not going to put a 50 on something that's not inherently on a specific side of the body. So, if you're in the middle cavity, working on the stomach or something, it's not necessarily anatomically based. So just because you're in the right side of the stomach, if the procedure itself is not inherently anatomically based, then you wouldn't use a anatomical modifier. And I did put the surgery indicators on here just to give you a little bit more context to that. So a 0 means that a modifier 50 is not billable. A 1 means that the 50 is appropriate. A 2 indicates that the modifier 50 is also not billable because it's already inherently a bilateral service. A number 3 indicates that it's also not billable because it's a radiology service. The number 9 simply means that the concept does not apply. So those are really important takeaways to remember when you're billing this modifier. If I'm not familiar with the code, I'm always going into my encoder. I use Optum encoder, and if you scroll down, it's going to give you the bilateral surgery indicator, and you're going to know right then whether that procedure allows this modifier. So I feel that two of the most either overused or misused modifiers is your modifier 51 and your modifier 59. So your modifier 51 is for multiple procedures. Okay, this is a modifier that is not applied to your E&M services. This is simply adding this modifier stating that an additional procedure was performed. There are some procedures that don't require a 51, specifically add-on codes. So if you're familiar with your CPT book, you'll know that you'll have that, um, the red sign with the slash through it. It's telling you that that service is not applicable to the 51 modifier, and you need to know which procedures you can apply your 51 to and which ones do not need the 51. That's another reason why a encoder or a scrubber is very important if you're not familiar with those specific guidelines, because you can run it through the scrubber and it's going to tell you whether you need to append that 51 modifier. So with our modifier 52, so modifier 52 is specifically reduced services. This is not discontinued services. We're going to cover that modifier next. This is reduced services. This means your provider is going to append this modifier on a procedure if they did not do the complete service. So let's say a specific procedure requires 3 different steps, and for whatever reason, whether it be something to do with the patient or another reason why they didn't feel the entire procedure was necessary for this patient, it's at the physician's discretion. But remember, their documentation has to support why they reduced the service, why they did not perform the complete service. And my example to this would be if the provider gets in there and they can't cross over to complete a PCI. If, say, there's a CTO, which is not very common, but you do see it in the cardiology world, where a vessel is completely occluded and they make multiple attempts to cross and they can't get the wire to cross through. So there are rules where, depending on how far they were able to get, for that PCI, you can append a 52 modifier showing that the attempt was made and they were able to make it so far. So that's really one of the best examples I can give, but there all are a lot of other reasons out there that a provider would reduce the services. Just make sure the documentation supports it. So with a modifier 53, now this is a discontinued procedure. So a physician may decide to terminate a surgical or diagnostic procedure due to extenuating circumstances. So this may be a threat to the well-being of the patient, or it may be that the surgical or diagnostic procedure was started but discontinued for another reason. Remember, yet again, as always, you want to make sure that your provider's telling you why they discontinued the procedure to support this modifier. So next we have modifier 62. So a lot of times you see this modifier used on major procedures. There are certain procedures where it requires two physicians from two different specialties to come together for one procedure. So provider A performs their specialty portion of the procedure, and then specialty B surgeon comes in and they perform their portion of the procedure. And that means that both surgeons are going to append the 62 modifier stating that they both performed their portion. Remember, both providers must document their own procedure note. This is not an assistant at surgery. This is two separate surgeons. Okay, so there's a big distinction there. Is we're talking about two separate surgeons, typically two different specialties, performing a distinct portion of the procedure. It is not a surgeon and a PA or a resident or whatever that just assisted opening, closing, those type of things. Okay, so just make sure you know the distinction between the two and that your providers are documenting appropriately to the portion of the procedure that they performed. So, in contrast, assistant at surgery, there are 4 different modifiers that we use for this, and they all have a different classification. So an AS modifier is going to be your physician assistant, your nurse practitioner, your clinical nurse specialist that assisted at surgery. Your modifier 80 is your assistant surgeon, and this is going to be if another surgeon assisted. Okay, another MD, DO, whatever the case may be, not a mid-level. Your modifier 81 is a minimum assistant surgeon, basically stating that it only needed a small amount of assistance, not throughout the complete procedure. Now, you're not going to see this used very often, at least I don't. The AS for the mid-level and the 80 for the other MD are going to be the two most common that you're going to see. But remember, the documentation must support it. Your provider cannot simply say, PA such and such assisted in this procedure, or just simply labeling them as the assistant. They need to document what that assistant did. They help with the open, the closure. Did they help in a specific portion that required more than one person to perform it? And then the last one is your 82. This is an assistant surgeon when a qualified resident is not available. So if you are in a teaching hospital and your hospital utilizes residents as an assistant, and you are unable to get one of those at the time of the procedure for whatever reason, then you can use the 82 to have an assistant surgeon only when you are not able to obtain a resident to do that work in that procedure. So now let's talk about some of the other modifiers. Okay, so we have our modifier 26. So this is going to be specific to procedures that have a professional component and a technical component. So if your procedure isn't inherently defined as the professional portion, say for example, an EKG. There are 3 CPT codes that tell you which is the professional portion, which is going to be your interpretation and your read. There's a portion that is just for the EKG strip, and then there is the complete EKG where your provider performed all of the components. But there are other procedures out there that um, do not distinctly define professional component only or technical component only, which means those procedures require the appropriate modifier for what your provider performed. So, for instance, on our echoes, if your provider is performing them in a hospital where they do not own the equipment, they are going to append a modifier 26. But if your provider performed that same echo in the office and they own their equipment, you can bill the global service. So you just have to know those details and make sure that your provider's documenting appropriately. So like I said, modifier 26 is specific to the provider performing the professional component. So this was the other modifier that I mentioned earlier that I feel like is either overused or just simply misunderstood. Um, I've seen so many denials for this modifier. This is for a distinct procedural service. This is when there is a column 1, column 2 code edit. You run it through your scrubber, and there's an unbundling edit for these 2 procedures, meaning that they could have some type of overlap between the 2 procedures, or the other procedure could be inherently included in the more complex procedure, or it's not typically separately billed unless it's under specific circumstances. Okay, so the main takeaway on the modifier 59, and you must know this, is the doctor must document that it was distinct and independent from the other service. Okay, that's so important that it's either at a different site, a different entry point, a different physician did it on the same day, or there are other circumstances where a few years ago they created the X modifiers that further define each of these scenarios, but typically across the board, most payers recognize the 59 over the X modifiers. So that will conclude today's presentation of a broad overview over specific types of modifiers that we see regularly within the coding world. I got my resources for today's presentation from Novitas, which is a Medicare contractor, as well as I included the link for the modifiers, the complete listing from Novitas. If you enjoyed today's presentation and you're watching this on the replay from YouTube, be sure to like and subscribe, and check out the Coding Corner on Facebook. I want to thank everyone for watching today's video, and we will see you next time.